specialist in child abuse in Maine, and he developed the first Maine statewide hospital and clinic protocols for child abuse identification and treatment. We also have with us today KBowden, who is the perinatal outreach coordinator at Maine Medical Center, and she speaks in Maine on topics related to infant safety and healthy pregnancy. And finally, Dr. JHayman is a pediatric hospital. This is the Barbara Bush Children's Hospital here at the Maine Medical Center, with a very strong interest in infant safety and safe sleep. So thank you all for joining us.
Sure. So I'll be talking first, and then Kelly, then Jen, and just to back up one. So the idea here is that we talk about, from my perspective, we talked about mandatory reporting, how not to miss abuse. And in many of the more serious abuse cases that we see in Maine, particularly those where children died, invariably professionals, in some cases medical professionals or mandated reporters, have missed an opportunity to prevent the subsequent death. So that has been the impetus for this discussion. And then Kelly will talk to you about shaken baby prevention, the period of purple crying, and Jen will talk about safe sleep. So a quick case scenario. This is from a couple years ago. Actually, twins are born. One boy, well, first home visitors, first month of life. These are Maine families, lay home visitors. I think there is this misconception in the community and among professionals that having people in the home acts as a safeguard against abuse. And in point of fact, abuse is a secret thing. It doesn't happen in front of other people. And families are fairly adept at hiding not only the abuse, but offering explanations for things and behaviors. So I am not convinced that with high-risk families, having services in the home acts as a deterrent to abuse. This may be true of low to moderate risk families, and I certainly support programs like Maine Home Families and visiting nurses, but I think we have to be careful that we don't assume that they are out there as protecting children from abuse. There were concerns, medium safety risk due to a dirty environment. 1 week well child check occurred. The other phenomenon that we see all the time, and in fact most recently in our most recent death, in every serious case we see, is professionals are involved with families and they never talk to each other. No one ever talks. The visiting nurse talks to no one. The home visitor talks to no one. The doc talks to no one. Child Protective Services talks to no one. And so there's no communication about the various risk factors in the home. So second month of life, prior to the broken arm, visiting nurse, second home visit, I think what the visiting nurse is looking for is the child being fed, what's the weight, what's the developmental status of the child. Folks are not out there doing what I would recommend they do, is asking about injuries, particularly any bruises, and that's one of the most important things I'm going to talk about, are the concept of sentinel injuries in these abused babies that allow us to protect them from future abuse. The home visitor finds out that the dad is explosive, that he has a temper. We would not just brush that off. If we get a case referred to us at the Sterling Child Abuse Program where the report is dad has a temper, we will often put those babies in the hospital, at the very least get a skeletal survey on the babies. 1 month well child check, both parents come to the well child check, office visit. Shortly thereafter, mom reports that dad said the baby got his arm caught in the crib rail as dad was picking the baby up, it broke the arm. He heard a pop. Radiology report noted a non-displaced hairline oblique fracture of the humerus. This was not a Maine Med radiology report. Our radiologist, particularly our pediatric radiologist, would say rule out child abuse at the bottom of that report. It didn't happen here. The primary care provider thought the mother presented well, as did the orthopedist. So there was this sense, and this is another fallacy in our work, that we can somehow tell who is abusing a child versus who is not abusing a child, who is telling us the truth versus who is lying. And I can tell you categorically that we are terrible truth tellers. So you can see a little hairline fracture, the midshaft of the humerus. The question is not how big is the fracture, the question is there's a broken arm in a 1 month old. But mandate there would be two things now. One, to report it to Child Protective Services. Two, to report it to us. And then for us, we would put a child like that in the hospital immediately. So then nothing happened. Home visitor, last home visit, they talk about the broken arm, discuss the period of purple crying. Visiting nurse comes in, and there's a history of bruising on one or both of the twins. And the primary care provider's office was called and agreed to see the child in 2 days. Another mistake there was to not see the child immediately, call us, have the baby admitted. Saw the baby on Friday. It's unclear whether the bruise was still present. I think one of the things folks try to do often is that we see a baby under the age of 6 months with bruises. The first thing we're going to do is get a coagulation study. And I can tell you in my career of getting thousands of coagulation studies, many hundreds of coagulation studies, I've had positives maybe two or three times. So the child goes home, visiting nurse notes the baby is somewhat symptomatic. The visiting nurses talk about the case, and they say, well, there was this broken arm, there is this question of bruising, but we think the extended family provides a safety net along with a doctor visit. Again, a very big fallacy. Daycare notes significant bruising. Pictures were taken. They didn't report it, and they're mandated reporters. So here's the photos on the upper outer arm. These, to us, would be classic grab mark bruises. These are not bruises from a 3-year-old toddler, which was one of the theories in this case. And then DHS visits the home because somebody raised concerns about the toddler being injured. So the focus is on the toddler. There's all this anchoring going on. We're focusing on the toddler. They hear about the broken arm, but that's not their case concern at the time. There are also other things going on. Caseworkers are heavily burdened with multiple cases. So the broken arm was sort of in the back of people's heads, and this happened to be a Thursday of a 2-day statewide conference. So the thought was, well, we'll pick this up again on Monday. Right? So unfortunately, he comes in on Saturday. And there's this initial head CT with old and new subdurals. There's his multiple rib fractures. Here's the head CT the next day, and this is a dead brain. So this is what we call a black brain. Profound hypoxic ischemic brain injury. Autopsy reveals everything we knew was there to begin with. Father ultimately confessed that the story about the crib rail was a lie. It was a lie. He actually had grabbed the arm because he was frustrated and heard the arm pop. In the fatal event, baby was crying, squeezed his head and threw him into a chair. I would also say that what we often do with babies is admit their twins to the hospital at the same time, and this guy's twin also had rib fractures and a subdural hematoma. So the goals we want to look at here for my presentation: learn how to avoid missing abuse, know when to be suspicious, learn how to report, know when to consider hospitalization, and know how and when to obtain subspecialty child abuse pediatric consultation. So we'll be talking about physical abuse, particularly abusive head trauma, a little bit, very briefly, sexual abuse and neglect and failure to thrive. This is a very quick overview. So child abuse and neglect, according to the MAINE statutes, mean any threat to a child's health or welfare by a person responsible for the child, and all those various types. The risk factors in the child include prematurity. These were obviously premature twins, drug-exposed or drug-affected babies, physical disabilities in the baby, normal colic, and Kelly will talk to you about the period of purple crying as a way of preventing these babies from getting shaken and or impacted, sustaining life-threatening brain injuries. Developmental disabilities, chronic illness, emotional and behavioral issues tend to be more commonly abuse related to older children like toddlers and older kids. Parents, depression, poor impulse control, substance abuse, abused as a child themselves, particularly if they were abused and were in the foster care system. And these are questions, by the way, I know we talk a lot about ACEs, but these are questions, when you're seeing babies, you should be asking parents these questions about whether these things exist in the home. Not necessarily to stigmatize them, and not at all to stigmatize them or report them, but at the very least to make sure the services are in place to work with these risk factors. Punitive child-rearing styles. Interestingly, in a study that was done on shaking, it's felt by parents that shaking a baby is less forbidding than spanking. Because spanking is, you don't want to spank a 3-month-old, but it's okay to shake a 3-month-old. Another problem with shaking, and Kelly might talk about this, is that it works. Baby's crying, you shake them, they stop crying. So you get this immediate positive feedback. Whereas if you spank them, they just keep on crying louder. Previous involvement with Child Protective Services. That means any involvement. That means a report was made to Child Protective Services. It doesn't mean that the case was even opened or that there was a substantiation. Any prior involvement with Child Protective Services is the strongest predictor of future involvement. And previous involvement with law enforcement. Risk factors in the environment, social isolation, domestic violence probably the biggest. Unemployed or financial problems. We know the Great Recession caused an increase in abusive head trauma in this country by 50%, the 2009 recession. Single parents, particularly if there's an unrelated male in the home. However, I will say that the two most common perpetrators kind of equal for abusive head trauma are the boyfriend, unrelated boyfriend, and the father are both equally common. So physical abuse, injury inconsistent with the explanation being offered, and that requires some degree of skepticism. I think we tend to be fairly gullible. Our presumption in regular medical care is people will tell us the truth because they're looking for help. In child abuse, there's no motive to tell the truth. The motive is to lie, to avoid getting into trouble. Differing or changing explanations for the injury, recognizing that people saying the same story doesn't guarantee you that it's the truth. Injury inconsistent with the developmental age of the child, any bruise or fracture in a non-ambulatory infant, particularly under the age of 6 months. And obviously if someone says the injury was inflicted. Another indicator that we pay close attention to is whether there have been previous injuries. And we often, always in cases, kids coming into the hospital with severe abuse, ask, has there been any other bruises? Any other injuries of any kind? So the last case we had, the mother said there were bruises on both sides of the chest after the baby was alone with dad. And the dad said that that was because he was pushing the knees up into the chest to get the baby to pass gas. So I don't care why those bruises are there. The fact that there were bruises previously indicates that the child was physically abused. Atypical location for an accident. Anything under the age of 6 months is atypical. We do not see accidental bruises typically in a child under the age of 6 months. But as we get older, we're talking about buttocks, neck, pinna, particularly the ears, particularly the left ear, right-handed perpetrators. Upper arms, upper legs, multiple locations, particularly bilateral. Patterns of an implement, the most common implement being the hand. Any injury, no matter how minor, less than 6 months, and the old dictum is if they can't cruise, they can't bruise. So bruises, burns, fractures, head trauma. So this pattern of bruising in this child's face should be recognized as virtually diagnostic. If anything is diagnostic in child abuse, this pattern of linear bruising is virtually diagnostic of a hand slap, particularly on the left side of the face. There really is nothing else that can produce that kind of pattern. Bruising on the buttocks, in this case, this is bruising from a belt, not from going down a slide. It's not from sliding down the stairs. So, a quick review of bruises. Burns, we look at immersion burns or dry contact burns, spill or pour burns. A child's carrying a cup of hot tea on a platter. This story is my daughter's story. She's like 7 years old. She's carrying this hot tea on a platter. She falls. The tea spills on her. Happening to be visiting relatives in Philadelphia when it happened. Had to go to the drugstore and beg them for medication. She was fine. But so there are accidental spill and pour burns that can occur, but we're looking at bilateral, symmetrical, well-demarcated lines with no splash marks, cigarette burns, hair dryer burns, lighter burns, particularly the Bic lighters, which Oddly enough, many of us in the field know exactly what a Bic lighter burn looks like. It has a rather distinctive pattern. I once saw a child who had multiple Bic lighter burns, as did the mom. And sometimes that's used as a kind of tattoo, right? So this is the immersion burn pattern. Fractures, we should think about abuse in all fractures. And we're happy to take calls about any case, anytime, 24/7. Myself and a pediatric nurse practitioner, who's a child abuse specialist, Sarah Kamiri, are always available to take calls on these cases. We particularly worry about any fracture in a child under a year. There are occasionally fractures, particularly linear skull fractures, that can be accidental in those cases. Collarbones are uncommon fractures, but they can be accidental as well. We particularly are concerned about long bone fractures. And the shape of the long bone fracture, they used to teach that if it was spiral, it was abuse. If it was transverse, it wasn't, or vice versa. I could never keep it straight. It doesn't matter what the shape of the fracture is. It matters the age of the child and the bone that's broken. There obviously are, of course, toddler fractures that occur in 2- and 3-year-olds where they fracture their tibia, sometimes their femur. We're also happy to get involved in those, but most of the time, those kinds of isolated fractures are not abusive. And this is a transverse fracture in a 6-month-old that was offered by mom as falling from the changing table. It's not possible to get a fracture like this falling from a changing table. This is a grab bending fracture. Here's some fractures of the metatarsal, somewhat uncommon, but we see them because we get 200 skeletal surveys a year in our program from kids throughout the state. And the theory was offered that this happened from the child bouncing in a bouncy seat or swing. We got a skeletal survey and found fractures of the, does this have a light? Oh, it does have a light. Wait a minute, the light doesn't work. Works there, but it doesn't work there.
Yeah, it won't go on LED on LED.
I learned something new today. What if you had special, like, X-ray glasses? Yeah. There's a fracture across the distal tibia and a rib fracture in this baby. And this is a 2-year-old, typical jumping, running, falling, twisting, toddler fracture. Sort of oblique, sometimes spiral, sometimes displaced, the mid to distal tibia. Skeletal surveys, we're very good at getting skeletal survey using the right technique in the Portland area. Some other places are not that good, and we often have to repeat the skeletal surveys because they send us a kid who's had 6 X-rays. We want 20 X-rays, and we want them to be high quality, high resolution, high detailed X-rays. So shaken baby syndrome, violent acceleration, deceleration injury with or without impact. That's why we don't use shaken baby syndrome as a diagnostic term anymore, because oftentimes there's impact and not just shaking, or sometimes just impact. So the incidence is thought to be maybe 5 or 6 cases a year in Maine. We're actually seeing maybe as many as twice that number. And we could talk about why that is. Victims usually under 1 year of age, peak incidence that's 2 to 4 months, characteristic injury of the brain, bone, eye, 15 to 25% mortality. The majority of survivors have some form of long-term disability, and some of those kids are profoundly damaged. So an important concept I wanted to talk about is the idea of sentinel injuries. This is any injury that you hear about or see. So hear about or see in a baby under the age of 6 months, maybe even under the age of a year, but once they start cruising the furniture, you know, they're going to get injured. And these are injuries of any kind, need to be researched and evaluated quite aggressively. And we would encourage people to not assume that it was the toddler who did it. That's the story we always hear, that it was the toddler who did it. The last 2 children who died, the story was the toddler caused the bruises. They are not common injuries in non-abused infants, and even if it's only by history, we should be doing a workup on these babies. I know it seems aggressive, but in fact, you know, that baby, that 1-month-old with that bruise ended up going home and coming back with a subdural hematoma a couple months later. So this is the current child abuse reporting law. It's important for you to recognize this. This is based on that first case that I presented to you, where if you see a baby under the age of 6 months or otherwise non-ambulatory who has any of these injuries, you are mandated to make a report. It's no longer discretionary. So the baby who has the arm fracture at 1 month of age, that is not a discretion that you can say, I believe the story, therefore it must be accidental. And Kelly's going to remind me to tell you that this does not include birth injuries. A clearly identified birth injury is not a part of the mandated reporting law. I would also say that substantial bruising or multiple bruises is not enough. I would say any bruise. Because if you looked at the baby, I showed you the photos earlier of the arm, I don't know that I would call that substantial or multiple, but clearly it was an inflicted bruise. A recent baby we had a subconjunctival hemorrhage. Was one of the indicators of prior injury. That would not fall under the law, and yet if it had been identified and reported and investigated by us, that baby would not have died. So, sexual abuse, a couple comments. Obviously, there's some behaviors that can present with sexual abuse concerns. Children present because there are disclosure or other concerning statements, or because they were exposed to someone who may have abused children. We see a lot of kids where there's, so to speak, kid-on-kid sexual abuse concerns, and we're happy to look at those to see, particularly if it means that the initiator of the behavior has been abused themselves. Unexplained genital injury, sexually transmitted infections, pregnancy. We don't see very many sexually transmitted infections. The one we most commonly see is venereal warts or condyloma acuminata, and we do work those kids up for abuse. Many of them have not been abused. They probably got it from mom at the time of pregnancy or delivery. Lately, we've seen a bit of a rash of gonorrhea and chlamydia, more than we had seen in years past. Sexual abuse exam. If you get these kids come in, you should at least take a look for obvious trauma, document any injuries, look for other evidence of abuse, do a head-to-toe exam. Be careful not to over-comment. Don't say because the exam's normal, the child wasn't abused. Don't say because you think the exam's abnormal, there must have been abuse. Refer them to us for a definitive exam. A little bit about neglect. Neglect is ubiquitous. It is the most common form of child abuse. 60% of kids who are reported to child welfare agencies in the United States are reported for neglect. It is probably the most damaging in the long term in terms of children's later development and welfare. Non-compliance with healthcare recommendations, particularly if that puts the child at risk. Failure to thrive, we have a failure to thrive clinic where we see these kids often. Unmanaged obesity where there are comorbidities. Illegal drug-exposed newborns, ingestions, especially recurrent, exposure to domestic violence, and unmet developmental needs when our services are available and not accessed. So, for example, the child's got bad teeth, but they can't get into a dentist. I'm not sure I'm going to fault the parents for that. And here's a classic growth chart for some of the failure to thrive cases we see where this child ultimately recovered, but ultimately had to be removed permanently from the family. Oftentimes, we can short-circuit this and avoid this by getting involved sooner with the family and preventing it being so long, so bad. Because you look at a chart like this where the child had failure to thrive going on for 9 months, and you say, geez, we've already lost a lot of ground here that we're never going to get back. Okay, when you suspect, remain non-judgmental, take a careful history. Saw a family this morning I've been following for failure to thrive. Foster family, 2-year-old jumped off a drum, broke his tibia, went to the hospital, and according to the foster parents, and take this with a grain of salt, they were accused of abusing the child and were told they couldn't be in the room with the child. So I think that was a bit premature since this ended up being just a bad toddler fracture. Take a careful history, examine the child, document everything, and please feel free to call us anytime. Consider hospitalization. We're very aggressive about hospitalizing these kids. JHayman at Maine Medical Center knows this. Maine Med knows this. We will put kids in at 3 months of age with a bruise. We put them in for a workup. Report to Child Protective Services. So you're a mandated reporter. I don't think I have to go through this. You're a mandated reporter. If child abuse is still in your differential after your initial assessment. There's a lot of reasons why reporters don't report. They don't recognize abuse, either because they weren't trained or because they have limited experience. They know the family, and I don't know that anybody knows anybody for that matter. Failure to report because they're afraid of being wrong. This is what you do when you suspect abuse. There's a process after the report. We can talk about this at some point, but if you are unhappy with the response you're getting, ask to talk with a supervisor. I always ask to talk to supervisors. Every place I call, I ask to talk to a supervisor. If I call Macy's, I ask to talk to a supervisor. Where you can go wrong by failing to question the history, failing to consider risk factors, failure to get appropriate tests, using diagnostic tests of poor sensitivity and specificity such as parental behavior and parent-child interaction, and fail to report to Child Protective Services, fail to contact us. So this is how you can get a hold of us. It should be in the handouts. Hopefully you've gotten a copy of that. And I'm going to speed along and have Kelly talk about infant crying.
Okay. So Dr. Ritchie mentioned the incidence of abusive head trauma. I'm not going to belabor that, but the point that I did want to make was that bottom point that we know that for every baby that's shaken and presents to the hospital, there are probably many more who are shaken and they aren't stunned enough, they aren't impacted enough to present to the hospital. So we know once they got to the hospital, there may be multiple previous shaking episodes because the shaking works. He already mentioned the most common perpetrator is the male in the home. Next common is the female babysitter. So the case that I always talk about is the Don't Shake Jake program and Pam Belisle, whose son was killed by the grandmotherly type babysitter. And moms usually don't shake their babies. They're the least common. So one of the things, the Period of Purple Crying is a program that we implemented in 2008. And every family has been receiving the materials since then, I hope. Emily, did you get them when you had your first baby? Don't remember? So this is an evidence-based program that talks about normal infant crying. And so it started with Barry Brazelton in the 60s researching this and talking about the infant crying at about 2 weeks of age is about an hour and a half to 2.5 hours, and that crying increases over the next couple of months, so that by 2 months of age, some babies are going to cry as much as 5 to 6 hours a day, and that's still considered within a normal range. It's what people call you and bug you about. Interestingly, in British Columbia, and I think it's been replicated again in Utah, families who had these materials and they knew about the normalcy of crying, it actually decreased calls to the pediatrician and decreased emergency room visits. So this should help you at some point once the messaging gets out. And this has been replicated across cultures. So they went to Botswana and observed the Kunsan hunter-gatherers where they carry their babies everywhere, they breastfeed all the time. Same crying curve in a number of different mammals as well. So families receive either the DVD and booklet in the hospital, or as of April 1st, there's now an app for that. And I did bring a few copies of the app. Has anyone seen the Period of Purple Crying video? So it's a 10-minute video that talks about shaken baby prevention. And there's a new segment, it's a 15-minute segment that talks about soothing and how to cope with crying. And we would encourage families to watch both segments. We, right from the beginning, had included public health nursing and MAINE families in the education that we did. And so they are already out there supporting. We're here to ask you to support the program as well. There have been public service announcements in the past. We haven't had any recently. And the CLICK campaign is the click of knitting needles, as we asked people to knit purple caps, and that was a national program. So there's the soothing segment. It's all those tips that I remember my mother and aunts talking about, like putting the baby in the car seat and driving around, and putting the baby like in a front pack and vacuuming. So there's nothing weird or scary about the soothing tips, putting the baby in a stroller and going for a walk to help calm yourself down. So purple doesn't mean that the baby cries so much that they turn purple. But it's an acronym that talks about the peak of crying that I showed you, that it's unexpected. You know, when you get pregnant, you sign up for that smiling, chubby baby. You don't sign up for the 5-hour crier. That it resists soothing, so you can try all those tricks, and the majority of the time that'll work, but sometimes it doesn't. Babies will sometimes look like they're in pain, and that's very distressing to families, but it's long-lasting. And it happens in the evening when we're coming home from work and we're exhausted ourselves. So if you want more of the background, you can go on to the National Center website, which is don'tshake.org. And you can do this online training program. It's free. You would probably want to do the dose 2, reinforcing the messages. Has more about the evidence behind the program. And so really what we're here to ask pediatric care providers to do, and I know there's some OBs in the room, so you could help too. How much does your baby cry every day? Are there any new male caregivers in the home? How do the caregivers cope with infant crying? Who's taking care of the baby? And have all the caregivers watched the period of purple crying? I did bring a few little brochures as well, and I'll leave those for you. And I've got extras for the other sites. For families who are tech savvy and they want online resources and support, purplecrying.info. There is a chat room that's part of this. It's a monitored chat room, so that there's no extremes of stories there. And I'm going to turn it over to Dr. Hayman.
Yeah, I kind of just do it.
Right. Well, I am going to finish up today. We're here, like Larry said in the beginning, to talk to you guys about how to keep babies safe in our community. And I'm going to talk about safe sleep. I think at this point a lot of providers have heard this term. It's not a new thing anymore, but when we first started talking about this, it was kind of an unknown thing. I spend most of my time actually on this slide with folks. I think especially the pediatricians in the group will probably be most interested in hearing what's actually happening here in Maine. And again, when we first started talking about this, people said to us, we don't really believe that we have a problem with this. We're a small state. We're a different state. This doesn't apply to us. And hopefully these numbers will show you that this does apply to us. And this started back, actually, Dr. Ricci and I started the 2002 to 2006 cohort looking at all babies who died unexpectedly in Maine. If they were a preemie, if they had a heart problem, if they died of sepsis, those were excluded. These are otherwise well babies who died for no reason, negative autopsy and negative death scene review. And you can see the numbers here, similar to quote-unquote classic SIDS. They're about 3.5 months of age. But importantly, and Kelly mentioned there's some OB folks in the room, so I'm going to ask for your help as well. The youngest babies that we're seeing dying unexpectedly were 2, 3, and 4 days old. So these are babies who are not even making it back into our offices for their 1 or 2 week weight check or bilirubin check. So it's really important to get this message out before babies are born or, in the newborn nursery. But for those of us who've had babies, in the nursery, you're tired, you're stressed, it's a lot of emotions. You don't take in a lot. So we would love in the OB offices to start getting this message out. 56% of the babies were bed sharing. 2/3 of the babies were not on their backs to sleep, so they were on their bellies or their sides. They had too many things in their sleep space with them, like bumper pads, pillows, blankets. And only 3 out of the 54 babies that we looked at met the AAP criteria for safe sleep, so 94% of them were sleeping unsafely. This isn't to say that we can say definitively that these babies died from sleeping unsafely, of course. I can't make that causation, but there really was no other risk factors found other than the unsafe sleep. We repeated this in 2009 to 12, and I'll have some snippet data from 13 and 14 a little bit later, but 2012 is our last complete year of data that we have. And the numbers are very similar. Again, over half were bed sharing, about half were not on their backs. And importantly here, we started to track some new trends. You can see that 4 babies died while sleeping in a boppy, one of the breastfeeding pillows, which is fantastic for breastfeeding, but it's a horribly unsafe place to stick a baby for sleep. And these babies were either put in the boppy in a crib, and I have a picture of what happens. They sort of scooch down and asphyxiated that way, or they were put in the boppy on a couch. A couch is the least safe place to sleep with a baby, and kind of got trapped in the pillows and things like that. We started to look at who was smoking because we know that's an independent predictor for SIDS, and you can see about half were smoking. And another thing that we really started to drill down on based on feedback from both providers and the public, which was, you know what, that's great, your safe sleep message, but that doesn't apply to me because I'm not a methadone mom, I'm not on drugs, I don't drink. The perception is that only people who are using substances or on replacement therapies for those can smother their baby during sleep. So we said, let's look at this. And you can see that only 22 out of the 49 who died had parents who used drugs or alcohol. I'm going to talk to you in another slide about how if you do use drugs or alcohol, that risk doesn't even add to the baseline bed sharing risk, but it multiplies. But even without those risks involved, babies are still at risk and are dying in Maine. And then the last thing, we are starting to see more people use the wearable blankets, the sleep sacks, or the blankets that have the wings that you can swaddle the baby in. And that's good. We want that. We do know that those are safer to sleep in than doing the typical swaddling blankets. But we did have 2 babies who died in Maine who were wearing the sleep blankets after 2 months of age with their arms swaddled in the wings. And that's a risk factor because if the baby then rolls over onto his or her tummy, they can't use their arms to push up and turn the head. So an important message is to make sure that your families are using these before 2 months of age, and at 2 months the arms need to come out. So either get stacks that don't have the wings, or the wings can just go around the torso with the arms out. Just a quick example here. You guys can all, I think, intuit why this is a problem, but this baby can asphyxiate in a couple of different ways. Just a couple of statistics so that hopefully if you don't know a lot about this, you can walk away with this saying, all right, you know, I believe these guys on this safe sleep thing. This is one of the seminal articles on this subject, and you can see that if you're bed sharing with your baby as opposed to the baby being alone in his or her crib, that baby is 5 times more likely to die. If you add drugs or alcohol, like I said before, that risk multiplies. The baby is now 50 times more likely to die. And in this study, the drugs and alcohol is not parents who are very, very inebriated or out of it. It's the equivalent of drinking 1 to 1.5 beers before going to bed. So this is not necessarily people who are even drunk. If you look at the literature, you can have odds ratios of up to 100 for bed sharing with significant drug and alcohol use involved as well. I'm not going to belabor this. You guys probably know most of these recommendations. Just a couple of things. In the 2011 update from the AAP, it was the first time we talked about room sharing. Do people here recommend that for families at this point? Room sharing is the baby in a crib or a bassinet in the room with the parents, just not in bed. And that's the safest place for a baby to sleep. And one other thing to remind your families of, people are freaked out about SIDS, understandably. It's, you know, as a parent, it's one of your biggest fears. But this was the first time the AAP really said, don't spend your money on all of these things that promise to reduce the risk of SIDS. None of them have been studied, none of them reduce the risk of SIDS, and a lot of them actually are entrapment hazards. So the wedge positioners that go in between care providers in the bed, if you look at the Consumer Product Safety Council website, there's hundreds of reports of babies smothering in those things. So really the baby on his back in a wearable blanket alone in a crib is really all we can do to try to prevent against SIDS. So to highlight what was going on in 2013 and 14, and Kelly and I actually on Monday, right, next week from Monday, are going to the medical examiner's office, and we're going to actually look at all of the charts. So I will have more data from 2013 and 14 after that. But we do know some clusters that have happened because folks contact us when these occur. In September 2013, 5 deaths in less than 1 month in a very specific geographic area in Maine. In 2014, similar patterns in the late fall, early winter emerged, including the PICU doctor calling me about a baby who made it to the PICU after an asphyxial event while sleeping on the belly, and similar instance in a daycare. Both of those babies made it to the PICU but ultimately died. So we think, why are people sleeping with their babies? A lot of it has to do with myths. People worry about positional plagiocephaly or flat heads. So, you know, you can just tell your families when the babies are awake during the day, stress tummy time, that will help that head kind of round out. And nobody's head will remain permanently flat from sleeping on their back. They will round out if you give it time. People worry about appendages and heads getting stuck between the crib slats. New industry standards make it so that the slats are appropriately spaced so a head cannot fit through there. Hopefully there are no old cribs because the drop side cribs have been banned, but if you have a family who's using an old crib, if they're worried that the slats are too far, you can slip a soda can, a 12-ounce soda can in between, and if you can fit them, those slats are too far apart. People talk a lot about safe bed sharing, and that's probably a topic that we could talk for a whole hour on, and I know I'm similar to probably most providers in the room that we understand that we can tell parents this is the best thing you can do, and a lot of parents are not going to follow that. So you have to talk about you know, risk mitigation and how to keep the bed sharing as safe as possible as you can. But I always tell families, there's been studies about people who've done this safe bed sharing, and that means only one provider in bed with the baby, no pillows, no blankets, the mattress pulled up from the wall so the baby can't get stuck between the wall and the mattress, and the mattress directly on the ground as opposed to on a box spring. So there's all these kind of rules that go into safe bed sharing. And we've studied that. The Canadians are ahead of us on this, and they found that 100% of the babies who died while the parents thought they were practicing safe bed sharing, they actually weren't. So the point is, it's very hard to do this safe bed sharing. For sake of time, I'm going to go through this just because I don't know if you guys are like me and sort of fighting a little bit of a battle in the hospital with your patients. I just want to say that everybody worries about reflux, and if a baby has reflux and vomits and chokes, this is what everybody gets upset about. So I will see people recommend to elevate the head of the bed, or in a spitty baby, to put the baby in a car seat after they eat. Those two maneuvers, head of the bed elevation and car seat positioning, are actually much worse for reflux. The car seat makes sense, I think, if your baby is all, you know, scrunched up, you're putting a lot of pressure on the stomach, and the LES is not tight, so they're going to reflux more. But we've done pH and impedance probe studies, the GI docs have, and they've actually shown that reflux is the same or worse with the head of the bed elevated. So honestly, the only thing to do to prevent reflux, if you will, is really upright positioning for 20 minutes after the baby eats. Or I tell families, just be prepared to do a lot of laundry. This, you know, your baby will grow out of this. And a couple of things, I'll just go through this really briefly, but this is really helpful when we've talked to families and kind of lay providers to understand why we don't want the baby on their belly in terms of a choking risk if the baby does vomit. Here the baby's on the back. Obviously, if milk or formula comes up here into the esophagus, it might fly up the nose because, right, that happens when babies regurgitate, but it's not going to jump up against gravity and sneak through the epiglottis and down into the trachea. Anywhere, it's going to go back down the esophagus. In contrast, if the trachea is now the most dependent point to gravity, you can aspirate. We all know the epiglottis is not very well innervated by the brainstem at that point, so you may have even silent aspiration and not even know it. So the milk or formula may come out the nose and the mouth, or it may kind of fall down with gravity and get right into the trachea. So this has helped a lot of like grandmothers who have always said, put your babies on your belly to sleep because if they vomit, it'll come out of the nose or the mouth, to kind of understand why that is not the case. And we are right at 1 o'clock, So I'm just going to kind of go through sort of our summary points here, and I think we can take questions for 25 seconds before you guys have patience.
So I did bring the posters. These are from National Institute for Health, and the Maine Children's Trust pays to make copies. So there's some of those. There's some of these. There's some of the abusive head trauma prevention. And these are the web apps, so up to 5 devices. So maybe if each office setting took one and downloaded it, then you could all watch the materials and view those. Any questions? I don't know, off-site if they call in.
Yeah, they can chime in.
Okay.
Larry, particularly for you, is there any way of standardizing the concept of a skeletal survey so that every hospital, every place that does radiology orders the same panel?
We're better at it than we used to be, and it's very dependent on the hospital. Now, with Spectrum Medical Group taking over the world, we're getting better. The hospitals are doing the full 20-view skeletal surveys, but all we can do is make recommendations to the Department of Radiology. The American College of Radiology, American Academy of Pediatrics, both have a series, exact standardized 20-view series that are recommended, and all we can really do is tell them we'd like them to do that. And I have to say, many of the hospitals now, particularly the bigger hospitals, are very good at that. Yeah.
My second question was, got a sense of long-term families who do it. What would you consider a success story? How often do you see those families?
Well, the best success story is when we say it's not abuse. When a success story for a relatively low-risk family or medium-risk family where the abuse is not very profound is either maintaining that family relationship with appropriate supervision or reunification, and we do see that. The impediments to that tend to be oftentimes underlying personality disorders in the parents, multi-risk issues in the families. I think the other aspect of success that we see are when babies are taken away from clearly violently abusive families and not reunified. So how often do we fail at any of those? The follow-up is not great. We do sometimes fail. The re-abuse rate of an abuse is high. So that's the thing we like to try to avoid.
And Larry, would you say that multi-generational poverty influences that? I'm thinking of the article you recently shared, sort of about the little guy who sort of, if you can't break that cycle of poverty, that's going to impact future generations. And
right, poverty is oftentimes one of the underlying sort of buttresses for the other issues, such as limited resources, isolation, lack of education, poor prenatal care. All those issues tend to interplay under the sort of umbrella, if you will, of poverty.
If you're taking a child out of home, but they're going into a home that has those same stresses due to poverty, et cetera, it's hard for that child to break out of that, right?
Right, and so you have to be careful. We hate to see the failures where, I think the worst failures, obviously a child going back to a home and being re-abused, and we see that. The other bad failure is we take a child out of the home and put him in a resource home, a kinship home, where they're not better off. And that's the long-term adverse effects of that are quite profound. Yeah.
This might be an obvious answer, but why is there such an emphasis on reunification? I mean, my experience is that it's not great, but I would say it's universally not.
So we are a family-first country. The federal mandate for child welfare is reunification. Has to be the first priority. And that it's not in the best interest of the child. That flips. Let's say you have a child where, let's say you have a twin where the sibling was killed. Then there is no reunification mandate. Then the mandate is the parents have to prove that they're suitable to take the child back, as opposed to the state having to prove that they're unsuitable. But it is sometimes difficult to accept that reunification is the first mandate as opposed to child welfare. But it is the federal mandate.
So then there's also a shortage of foster homes in the state, so if you remove the child from the home, where do they go?
And, you know, the DHS often talks about the least restrictive environment. So I used to argue about kinship placement, wondering if that was suitable. I think we've gotten more sophisticated and better with our kinship placement. Not ideal, and not all foster families are ideal either. You can take a failure to thrive baby and stick them in a foster home where there's 5 other children, they're not going to thrive. But good kinship placement, and I've seen some great successes with kinship placement, it really can be of value to the children. I also have to say that sometimes parents can change. I don't know how often it happens, but it's always quite gratifying to see a parent come back and they've just turned their life around. And I've seen that on occasion. It's probably, I don't know why it happens. I think it's despite us. But it is quite gratifying to see it happen.
Thank you so much for coming.
Yeah, pleasure.